So thank you for the introduction, Deborah. It makes me sound like I know a lot about all sorts of things, and actually I probably know very little about a lot of things these days. When I started as a lung cancer nurse, we hadn't invented all of these things that you now are all receiving. And we had a very, very different outlook for our lung cancer patients. My background was as a palliative care nurse before I became a lung cancer nurse. And that was because the nature of lung cancer was very palliative. But happily, over the course of the last sort of 15, 16 years, things have changed remarkably, and my job has also changed remarkably. But despite what Deborah says, I probably don't know as much about ALK Positive patients as you all do, so forgive me my ignorance. But what Deborah asked me to talk about today was, what is a lung cancer nurse specialist? Because we know that a lot of patients may well not have had contact with a lung cancer nurse specialist. There are over 300 of us across the UK, Scotland, England, Northern Ireland have got 2 for the whole of Northern Ireland. So we're sort of quite a big community. But when you think that we have probably 48,500 patients to look after between us, sometimes we are a bit thinly spread. And the National Lung Cancer Audit found last year that probably only 75% of our patients had contact with a lung cancer nurse at any point during their treatment, and fewer than that had them available to them at the point of diagnosis. So that's something that we've really got to work on, and something that Lung Cancer Nursing UK is working as a bit of a pressure group with the government, in actual fact, to try and get the numbers of lung cancer nurses up so that we can support more patients. So what does the lung cancer nurse do? It's a bit like asking, what did the Romans ever do for us? And I don't know, was that Monty Python? We sort of don't know what we do until we find out what we haven't done. I think that's the way we look at our role. We talk about supporting our patients, but what does support mean? What does support look like? And that is very different for every individual patient, but it's also different for all of the nurses. We all work in different centres with different setups. Some of us work in big treatment centres like the Christie in Manchester. One of my colleagues works very particularly with stage 3 lung cancers that have concurrent chemoradiotherapy. She doesn't know anything about ALK positive patients, really. She doesn't know anything about the surgical pathway either. Some of us that work in smaller centres have the opportunity to work with all of our patients, regardless of what treatment pathway they're on. So some of us are very, very specialist, and some of us are much more generalist. But what we all hope to achieve is that we can offer emotional, practical support to our patients at every point in the pathway. So hopefully you will have met a lung cancer nurse at some point along the way and will know how to access them. And I'll just sort of give you a little advert now. There are 2 ways to access probably 3 ways to access your lung cancer nurse specialist. Ring your hospital and say, who's my lung cancer nurse specialist? If the receptionist on the switchboard doesn't know, which they might not, ring the PALS department, because they will be able to find us. And if you don't really want to do that, have a look at LCN UK website, because they will also be able to point you in the right direction if you haven't actually found your lung cancer nurse. I think the other thing that we also want to do is to make sure that we can help with symptom management. So any problems that you're having throughout treatment or after treatment, your lung cancer nurse should be an expert in that. But if they're not, they will know of other healthcare professionals that can help you, or other resources that will be available to you. In our trust, we have a big support from the Macmillan Integrated Therapies team. So we have physiotherapists, occupational therapists, dietitians, speech and language therapists. So we can access them for any of our patients at any point. So that's really important, that if you don't know where to find these things, the lung cancer nurse will be able to help you in that regard. So always access your lung cancer nurse, even if you think it's a daft question. It's a question that needs answering. And I'm very aware that here with UK ALK Positive charity, you've got a huge resource, and actually supporting each other. That peer support is probably far better in many cases than actually asking a nurse who doesn't know what it's like to be a patient. It doesn't matter how long we've done the job, we've never sat in your seat and worn your shoes. So having this room and this event is from from a nurse point of view is absolutely fabulous. And it's great to hear that you've all been enjoying yourselves. The other thing that Deborah asked me to talk about was nurse-led clinics. Now, what happened over the course of probably the last 15 years is that we've moved very much from a medical model of the doctors looking after all of the patients all of the time and the nurses helping out and supporting. We've moved away from that model largely because of the invention and the discovery. Invention's the wrong word, but the discovery of our genetic mutations and the needs for all of these new drugs. We actually found that we did not have the capacity or capability to look after all of our patients with a consultant oncologist all the time. And so probably about 15 years ago, I disappeared on maternity leave and came back to find that I got a clinic to run, and that was terrifying. But what we had to do was to find out ways of making sure that me, myself, and the lung cancer nurse population are capable and competent of actually reviewing our patients and having that clinical background so that we can assess when things are going right and when they're going wrong, and also have those skills to understand and interpret results and scans so that we can then help patients make decisions about treatment options and whether to continue with treatments, whether we should be managing symptoms differently, or whether we should be looking at dose reductions or indeed stopping treatment. So that became a huge responsibility for lung cancer, and not just lung cancer nurses, you know, all clinical nurse specialists have started to take on this role. So that was a steep learning curve. And if anybody asked me to do the medical prescribing course ever again, I'll say no, thank you very much. It was probably the hardest thing I've ever done. It really, really was. We needed to develop this role because we needed to make sure we could see our patients as frequently as they needed. I came from a very palliative background, and in the early days of my career as a lung cancer nurse, we didn't see our patients very often or for very long. And obviously with the creation of all of these new drugs, we are happily in the situation where we need to see our patients more often and for far, far longer, which is a really, really great place to be. I can remember sitting at a meeting with an oncologist many, many years ago talking about IBS and ABS, and we all sat there incredulous thinking, well, this is like science fiction, you know, we can't imagine this is actually going to change the pathway for our patients. But you are all absolute testimony to that these drugs have made a huge, huge difference to our lung cancer patients, but also to our nursing workload and the consultants' workload as well. So we needed to really rethink how we looked after our patients. So the purpose of these clinics is to ensure that we're delivering these drugs safely and effectively and on time. I think it's very important that we don't delay things for our patients, and we need to make sure that as the patient's advocate, we can see that patients are getting the treatments and getting their reviews in a timely fashion so that things don't slip and slide, or that you don't encounter symptoms and side effects that then mean that we need to make dose adjustments or stop treatments. So it's really, really important that we're seeing our patients on a regular basis. We also need to make sure that we're following you up in an appropriate fashion. It's all very well and good saying, yes, you're going to have a scan X amount of times a year, but if then you can't get the results to that scan and you're sort of plodding on with your treatment regardless, that's not an appropriate thing for our patients to be put through. And without sounding political, it's not an appropriate use of our resources either. And when the NHS is looking as it is today, we need to be making sure that we're keeping an eye on all of those things all at the same time. We also use the nurse-led clinics as an opportunity to actually tap in to not just the medical side of things. And I think that's a really important difference between a doctor's clinic and a nurse's clinic. And I know there might be a doctor in the room, so I've got to be careful what I say. Oh no, he's gone, that's all right. But nurses on the whole, hopefully speak from experience, actually take a much more holistic approach to that consultation. And actually we have, my colleagues would kill me, but we have more time. And we are actually able to sit down and find out what is it that really matters to the patient. And it's not just about the drug, because we're not treating a scan, we're treating a patient, and we're treating an individual patient. So we've got to make sure that not only that the drug is working, the side effects are okay or tolerable, and we're treating everything as we need to be, we need to make sure that that's fitting in with your day-to-day life. Many of you in this room are probably working. Many of you probably have young families or grandchildren that you're looking after. And actually, treatments and hospital appointments can really get in the way of that sort of thing if we overburden you. But we need to be really sure that the treatments that we're offering and the symptom managing that we're doing is actually fitting in and providing you with a good quality of life and not just quantity for the sake of treating the scan. So I think that's what nurses do well. I won't say better, because I might get shot. The other thing that a nurse-led clinic does or is it's not just run, well, it is run by the nurses, but it's not just the nurses that are there in that clinic. So in my practice and many of my colleagues' practice, we are sitting alongside, it's a dual clinic, so there's a consultant or a lung cancer oncologist will be sitting within our clinic at the same time. And often that's reassuring enough for the patient, because they know if there's a problem, you know, we can pop next door and have a chat with the doctor. But behind that, we've also got a big team. We've got a specialist pharmacist, we've got the physios and the occupational therapists that are around and about that we can call on for assistance, and we've also got the radiologists. So one of my biggest things is when, and it happens a lot at the moment, is when a patient arrives in clinic and I've got a scan and it hasn't been reported, and I'm sure every single one of you in this room has been to that clinic appointment and the nurse or the doctor has said, okay, well, I think this is what it says, but I need to get the report. Actually having that radiologist on hand to be able to ask that question, can you have a look at the scan for me? You know, can you tell me if this is a stable scan? Have we got a response? Are we progressing? You know, where are we at? Actually gives me the reassurance as the nurse that I'm giving the right information to the patient, and then therefore we're making the right decisions as to how to proceed with the treatment, or whether that's in actual fact the right thing to do, and should we actually be thinking about changing things, you know, should we be doing things differently. The other thing that's really important is that the patient and their families know that the doctor is on hand, so if there's ever any worry for them, we can call on the doctor. So it's giving that reassurance that actually they've not been abandoned and just left to the behest of the nurses and, you know, whatever they fancy doing. The doctors are actually overseeing all of that, so they have the final say. They rely heavily on our clinical judgment, but they're supportive of us and our expertise, which the nurse prescribing course, the physical assessment courses, and all of those years, you know, in the role have hopefully given to us. But at the end of the day, it's the consultant oncologist that will have that final word as to how we proceed. So we work very collaborative, I can't say it, we work together as a much wider multidisciplinary team. And I think the other thing that is really important that we want our patients to know is that the nurse is absolutely the advocate for the patient behind the scenes. So you might remember in the early days of the diagnostic pathway, it seemed that we were telling you we're going to have one thing done and then nothing happened for a few days or perhaps a few weeks. But actually lots of things might have been going on in the background, and the really big decisions are made at the multidisciplinary team meeting. One of my radiology colleagues many, many years ago said, as I sat there with a list of 37 patients to discuss, we should probably get the patients in the room, because then we can assess them, we can see what their performance status is, how active they are, we can find out what they want. And I said, we haven't got enough chairs. Where are we going to put 37 patients every week? And actually, how daunting would that be? It'd be like a terrible interviewing for, you know, will I get this treatment, and my life is on the line here, and do I get the job? So we ditched that idea. So therefore it's the nurse that becomes the advocate for the patient, and that's why it's so important that we know our patients. That's why it's so important that we've met our patients, so that we can put forward your ideas, your thoughts, your needs, your desires. And that not necessarily means wanting treatment. For some of our patients, there's definite limitations as to what they want. And so it's about getting that balance right. Again, we're not treating that scan, we're treating the individual that we're sitting with in clinic. And that's really important, that our colleagues that are looking at scans and looking at treatment algorithms and so forth understand who that patient is sitting in front of them in clinic. So that, I think that's one of my most enjoyable parts of the job is getting to know the patient. Most lung cancer nurses are incredibly nosy, and that's why I do the job. Because I meet all sorts of lovely people with some incredible stories and experiences. Some of them are a bit dull, but I don't tell them that. But, you know, on the whole, some really, really interesting people. But it just gives us that opportunity to get to know the patient. And as I say, you know, we can treat scans all day, but that's not who's at the end of what we're intending to do. It's a lovely job. It really, really is. The other thing as well, lots of patients worry that they might come to clinic and not be feeling very well. And historically, actually getting patients admitted from clinic into a hospital, the amount of times I've been told by the bed manager, you know, to send them home and get the GP to refer them in because that will be quicker, we've managed to sort out pathways so that we've actually got direct entry from our clinics through the acute oncology service and into a hospital bed should we need it for our patients. And I think that's really, really important to ensure that the patient experience is as good as it can be, particularly when our patients aren't feeling very well and have needs that need looking at, you know, quickly. So I think that's another really important thing to see. We don't need doctors for that anymore, which is useful because they're never around when we want them. Well, they are, but they're obviously busy doing very important stuff, you know, not trying to find beds for patients, it has to be said. I think in conclusion, the role of the lung cancer nurse, I'm absolutely passionate about, sorry, microphone. I'm really passionate about. I've just had a new member of the team join me 3 months ago, and I had a chat with her yesterday, and she's actually come from an ITU background, so very, very clinical nurse, very hands-on, everything's very protocoled hour for hour, and she finds all this sort of wishy-washy niceness really quite difficult to do, because she said that people tell me just to talk to the patient, I don't know what to say, and I thought, well, that's because most of your patients have been anaesthetised for a very long time. So I sort of thought she'd be very good at the job because she's talked to relatives of very sick patients, and I think she's got a lot of potential. She's a really lovely woman and she'll fit very nicely into the team, but it's about building that confidence of how to start that conversation, worried that the patient's going to ask you a question and you have no clue what they're talking about. So I think it's really important that we look at how we do our job and we're guided by our patients. And I think it's really important that we provide the service that you need. And I just hope that every single one of you in this room has had access or continues to access your lung cancer nurse specialist. There's lots of different models, as I said, about the country, lots of people doing things very differently, but there will be somebody for you if you need them, which is we're hoping that we'll be able to build the numbers of lung cancer nurses over the coming year. Somebody many years ago said what the workforce should be is for every 80 new patients you have 1 nurse, and that sounds great, but that was 20 years ago when all the patients didn't last very long, and now we've got patients that are coming for monthly reviews and monthly treatments for years. It's fantastic, but we need the workforce behind that to be able to continue the support and the work that we enjoy doing with you. So I think that's really important. I'm going to stop talking now because otherwise I will be here all day, and I know Dr. Bajal's probably got far more important things to say than I have, but if anybody's got any questions, I'm happy to take them either now, but I'll be hanging around all morning and over lunch, so I'd love to chat to you if I can. Oh, yes.
Two questions, actually. So the first one, as a patient myself, I know, and I'm sure you know, that every single ache, pain, cough, wheeze is the cancer.
Yes.
How do you, as a nurse, go about triaging that into you've got a cold, you hurt your back, versus actually
it's the cancer, yeah, and that's it's sort of almost an intuitive thing to do, and it's about that subtle questioning that you might find that you're interrogated in a clinic about all sorts of different things. You can't see why they're relevant, and it's about sort of working out the odds of, is this likely to be the cancer? Because we know that you've got a response on your scan, we know that you've been well up until now, and we know there's a huge amount of coughs and colds and flus in the community at the moment. But it's then about keeping a very close eye on it. So it's informing the patient that, you know, if this goes away after 5 to 7 days on its own, it was just a cold. If it doesn't, or if that ache and pain doesn't get a little bit better with rest, elevation, paracetamol, that's when we need to start intervening. I think the important thing that we say to our patients is don't sit on it, don't wait and see at your next appointment in 2 months' time whether that twinge was actually just a twinge. So that's why it's really important that you link in with your lung cancer nurses. People sort of say, oh, I don't want to bother you, I know you're really busy, but that's what we're busy doing, and that's what we're there busy to do. It's really important that you're getting those answers and that we're helping you to sort of work through the minefield of what's normal, and normal at this time of year, or normal for you. You know, I had a chap, he's a very young chap, and he goes to the gym very, very regularly, and he runs, and he puts me to shame, it has to be said, considering he's got stage 4 lung cancer. But he came in and he said, I've got really, really aching back. And when we sort of discussed things through, we worked out that he'd probably overdone it at the gym, but we decided we'd see him a week later just to make sure. And lo and behold, a week later of not going to the gym, things were improving. But we said we'd keep an eye on it. When his next scan was due, we would scan a bit lower down just to make sure. So it's just filtering through those things. Oh yes. What's your second question?
So from the outside looking in, the bottleneck in sort of the care pathways to look as a patient looks like radiologist.
Mm-hmm.
Is that correct, or are there other bottlenecks out there?
I think. Absolutely, and I think that's our experience locally in Shropshire. We have, obviously, the course of the pandemic gave us great problems of, cancelling a lot of stuff and only doing the urgent stuff, but now we're seeing all of those things that we'd cancelled are coming back through. So locally in Shropshire, we've got 2 new CT scanners, and we're doing appointments till 9 o'clock at night and on weekends and that sort of thing. So people are getting their scans in time, but we have no more reporting radiographers and we have no more radiologists. And actually over the course of the pandemic, we've seen a couple of radiologists take early retirements because it all just got, like now's the right time to go. So that bottleneck has very much come from the reporting side rather than the physical action of getting the scan. And I think that's definitely seen nationally. We know there's a national shortage of radiologists, and I know subsequent secretaries for health have said that we'll get more radiologists, but I'm not entirely sure where they're going to get them from, thinking about the years and years and years of training that they need to undergo. So you're absolutely right, that is the bottleneck. I think, I don't know what Dr. Bajal finds, but we do an awful lot of popping into the radiologist's office, quick phone call from clinic, can you have a look at this? A sneaky one on the MDT list, I know it wasn't listed, but can you have a look? Some of my consultant friends will actually sort of pop patients on the list with an unreported scan, knowing that they'll get a report without having to wait for another 6 weeks to get it. So it is a problem, it is a concern. We worry. I saw a patient in clinic. I do a surgical follow-up clinic as well. I saw a patient on her 3-monthly follow-up on Thursday. The chest X-ray from 3 months before still wasn't reported. So we're very, very aware, and thankfully, we've got lots of colleagues that can help. But that's not the way to do it. We need to sort out right at the highest level, getting more resources, particularly people. In to help us.
Because I hear about outsourcing as well. Does that help?
Kind of. It does, because essentially you get a report. Hopefully it tells you most of what you want to know, but often in real life experience it's telling me something, and I'm looking at the scan, and I'm a nurse, I'm not a radiologist, but I look at the scan and I think, oh, well, that doesn't sound right. Or they've reported something on the right and it's actually on the left, and that's when the alarm bells start ringing. So that's when you have to pop down to see your friendly radiologist and say, can you just report this scan? So for the stuff that's straightforward and normal, and not worrying, it's a great way to get those scans reported. But for a lot of our patients, there's lots of nuances and lots of, is it stable? Is it a partial response? What are you thinking? And it's quite subjective. And actually, when you're looking, knowing that the previous scan hasn't been looked at, you know, they're just looking at the one they've got today, that causes a bit of anxiety. You know, when you see I won't name the company, but it's one of their reports, you go, ooh. So yeah, so it sort of helps but doesn't. You're very welcome. Hi.
On the same subject, really, is there anything that we can do as a patient group to influence this? Is there would going through PALS, if every single person went through PALS every single time they didn't have a scan reported, would that be useful, or would it just be a pain in the ass?
I think a bit of both, to be honest. For the PALS team, they'll be like, oh, here we go again. But in actual fact, I think we have in our hospital a strategy whereby every month we're being told how long it's taken to get the reports through, how long it's taken to get the scans, how many we're fielding out to other companies and that sort of thing. So we know that, and we're trying to impart that information to our patients. But I think the real impact, and I don't have any influence on that because it's people far above my pay grade that can sort those things out, and you know, departments of health that are sorting it out. But I think having that patient experience and that impact of how it's affecting you as an individual, your family as a collective, because you're not getting the reports that you need and you're not able to make those decisions, which are important decisions, then I think actually if everybody contacted PALS every time, we would get a really good feel for exactly what the patients are feeling. Whether we could filter that much further up the food chain, I don't know if we could, but I think it's really important that I would always advocate if there's something that you're not happy about, speak to PALS. And people say, oh, I don't want to complain. It's like, you're not complaining, it's a service that you should be getting, so it's something that you need to do. So yes, I'd definitely advocate for that.